You guys, you're making this look like more of a ghost town, man. It would be better if we had a interactive session. So without you typing anything in the chat or just unmuting and saying something, makes me feel like I'm here alone. Anyone?
Morning.
Morning.
Now we can hear you and we can see your screen as well.
Okay, I've been told you guys haven't been taught the tumors of the bone.
Not yet. We haven't had that session yet.
Okay, thank you. So I think we should start. Yeah. So there's a diagram on your screen, and literally like someone to just unmute and tell me what type of tissue this is, where in the body are we, and what the, just a general knowledge. Just unmute and then you tell me like what you see on the screen. Not necessarily it doesn't have to be like the right answer, but just tell me like what's going on here. What do we have here? Okay. Anyone? Okay. I'll save you time. So here we have tumor, a bone tumor actually. This whatever is here is the bone. And the only bone that seems to be appearing like this manner with the head and all this going this seems to be the tumor. Okay. So what we have here is Ewing sarcoma. Okay, you'll be taught this. Hello.
No, it's okay. It's okay. Continue.
Okay. So this is Ewing sarcoma.
Shoaib, someone has said your voice is a bit low, that you should be a bit louder.
Someone is muted. Let's see if I can mute all of you guys.
Kalenda lala.
So what we have here is Ewing sarcoma, as I said. That would be our diagnosis here. But how do you get to know if this is Ewing sarcoma? Ewing's mostly affects the cortex of the bone. Okay, so usually you see the mass growing. Okay. Going to the next question, it says, describe the radiological features that you would see on a screen. I mean, on a patient Ewing sarcoma. The only thing that you see is something called concentric onion skin layering. Okay. I wish I had a radiograph of that so that I could show it. But later on, when I'm sending slides, I'll add it. The microscopic features someone gets to see. I think I should just expose the answers now that you guys haven't been taught these things. So the microscopic features that you get to see on a microscope is something called round blue cell tumor. Okay, and then it kind of appears like to be like a lymphocyte in a way. So maybe when you're doing this, you might think this this is a lymphoma or any other thing. But to distinguish it from a lymphoma, you have to do the immunochemical. The type of translocation associated with this, the above condition, of which we say is called Ewing sarcoma. It's called Ewing's translocation. There's a translocation on gene number 11 to 22. Okay, so the diagram you see here, this guy is called Patrick Ewing. Okay, I think now he retired from basketball. His career is so this guy, how I used to remember that translocation 11 to 12, this guy used to have this jersey number 33. So on addition to this and this, 11 plus 22, it gives it 3. And it kind of makes it simple since he has the Ewing name in his. Okay. The clinical presentation, we find patients to be presenting with pain, swelling, and tenderness. Okay. What part of the bone does it get to affect most of the time? The bone marrow cortex, and then the bone marrow cavity, and then it tends to go to the cortex now. So what are your thoughts on the prognosis? Okay, most probably you guys have been in pathology for around some months, Daisy. You know what prognosis is. This patient tends to have poor prognosis with 5-year survival. Since this Ewing sarcoma metastases to the lungs, pleura, the bones, and regional lymph nodes. Okay, I think we're done with that. So here is the case I formulated. It's about a condition that I couldn't get the picture. So the patient, who is Jane Doe, a 62-year-old retired teacher with history of hypertension and type 2 diabetes, presents with a 3-year history of bilateral knee pain. There's stiffness and swelling, more pronounced in the right knee. Okay, so the pain is described as aching and sometimes sharp, which is rated 6 to 7 out of 10. Aggravated by activities such as walking, climbing stairs, prolonged and standing. So it's relieved by rest, over-the-counter analgesics, ice packs. So she also reports to have morning stiffness lasting around 30 minutes that gets worse during the day. Okay, most probably, I think this anyone to confirm if you guys have been taught about hematology of the joint?
I don't thought about what?
Joints.
Yeah, they mentioned something about osteoarthritis.
Definitely. Okay. I think now someone can just answer this one. Okay, the trick is all here. Leave alone all these statements, the hypertension, type 2, this is just to make you confused. Okay. The trick starts from here: bilateral knee pain, stiffness and swelling, of which it doesn't necessarily have to be either osteoarthritis or rheumatoid or gout, anything. But this is where the trick comes. Just giving you that. Where it says she also reports to have morning stiffness lasting about 30 minutes that gets worse during the day. There's a trick between rheumatoid arthritis and osteoarthritis. The trick lies here. So one gets worse during the day, and then the other one gets better during the day. Okay, so reduced range of motion, and then there's occasional crepitus in the knee joint. So what's your diagnosis? I'd go with osteoarthritis because it tends to get worse during the day since it's a wear and tear disease. Two risk factors for the above conditions, which is osteoarthritis, we would have age as one of the biggest risk factors. Okay, so the patient has to be like around 60 years of age, and then obesity pair, it comes to play a role here. Pathological features that someone would see in osteoarthritis, you'd get to see. Okay, let me just ask you. Anyone to unmute so that you can tell us the answer? Just ideas, you know.
Was there something about enumeration of the bone? I'm off.
Yeah, emanation of the subchondral bone. Yeah.
Mm.
Okay, and then there are joints which tend to be affected more in osteoarthritis. Okay, also in the fingers. What type of joints does it affect?
Interphalangeal.
Which ones exactly?
Now I don't remember.
Okay, how many
Metacarpal?
interphalangeal joints do you know?
The metacarpal ones?
Mm-hmm.
Yeah, that's as far as I can go.
Okay, thank you, Gava. Anyways, it tends to affect the distal interphalangeal joint and the proximal. Okay, so there's something called Butcher's node. There's also something called evidence, something. I don't know. I just know how to write it, but I don't know how to pronounce it. So, where do you think which one comes? I mean, like the gani utapata in, let's say, like the DIP, the gani utapata in the proximal interphalangeal joint. Huh? Okay. The Butcher's node. How I remember this is I used the mnemonic BP, and I also use the mnemonic either DH or HD, with whatever works with it for you. I mean, butchered node goes to the distal, but I mean it goes to the proximal. That's BP, and then the evidence node goes to the distal. Okay, so the difference between these conditions, rheumatoid arthritis and osteoarthritis. When I say this is where the trick was. 30 minutes that gets worse during the day. The other one gets better during the day. I mean, with activities. Once someone starts walking and then they just get out of the bed, they start walking, doing activities, helping, just any activity. Okay, it gets resolved. That's rheumatoid arthritis. The other one is in rheumatoid arthritis, the DIP joint is paired. Okay, so in a sports scenario, most probably they usually get the diagrams, but not every time. Some extent, sometimes you'll find them formulating a case for you, and they give you about 1 minute to answer the whole question. Okay. So once the minute is over, the question disappear from the screen. So it's up to you to realize where the trick is. Don't struggle with a lot of words. Just read through the question. Whenever you find the most important thing, focus on that one, then get to solve the question. Okay, let's go to the next question. Okay, what do we have here? Someone to unmute and tell me what part of the body is this is.
Is that the wrist?
Yeah, definitely, that's the wrist joint. Okay, what do we have here? What do you see on the diagram? Most probably there's an abnormality here, of which it's so easy for someone just to pick it out. Okay, just have a look at the normal anatomy and then Tend to reason. Actually, it's not about a matter of reasoning. It's just something you just see it and you know this is. Someone to unmute. Okay. There's a mass here.
Someone in the chat has said necrosis of the bone. Let
Okay.
me check.
Okay. Yeah, but there's a
Of
mass
bones
here.
and tissue.
Yeah, there's a mass here. Whole bit. You can see it.
Yes.
Yeah. So usually it's quite hard. Okay, using the the growth features, it's quite hard to reason out with the what do I say with the okay, you can't reason. Okay, it's quite hard for you to get to know like this is this type of cancer, this type of disease. Okay, and most of the time, like you'd find like, okay, if this was dry and like it was in a formalin or any other thing, just like the other pots, you would have realized what type of tumor it is. But now that it's covered in blood and everything, and tissues are just around it, so it makes it quite hard. So that's why I just brought this diagram here. This is a histology of how the tumor looks like on microscopy. Okay, so this one, is there anyone who knows about this? Just like general knowledge. You've read it before, or you've seen it somewhere. Okay, so there's something called giant cell tumor. Okay, and then how you get to see that on microscopy, you get to find these giant cells which have multiplicated cells. I mean nuclei. It's very easy to pick it out. Okay, you can see there's one here, and there's other one here. There's so many here actually. There's other one here. There's another one here. There's another one here. There's another one down here. Okay, so that's the thing that would help you. Or even if you had an X-ray, X-ray is way better. Okay, you could just pick it out on X-ray. You can't confuse it with any other condition. Okay, let's get down to this. Describe the morphology of the above diagram. Already I've said this is a giant cell tumor, okay? And it's involving the wrist joint, but it's not going into the wrist joint actually. It's just affecting one bone, of which this is the radius, okay? It's affecting the distal radius, okay? There's a total destruction of the cortical bone, if you could see here. Initially this was the cortical bone, and then this is the marrow. And then when you come here, just like it disappears out of nowhere. Okay, and then this tumor tends to it tends to extend into the soft tissues. Okay, which are the muscles here and the skin. Okay, I think that's how you describe the morphology of this. Okay, two main microscopic components of the above mentioned, which we said is a giant tumor cell. I told you this, you guys, you just see something big here with multinuclear. So that is a giant tumor cell itself. And then it's also mixed with stromal cells. Okay. How does the above condition appear on an X-ray? I'd also attach one X-ray picture after this slide so that you guys could just know that this is giant cell tumor. So on an X-ray, it looks like a soap bubble appearance. Okay. So what part of the bone does it involve? The epiphysis. This is the epiphysis now. You know, there's the in bone. There's the epiphysis. There's the metaphysis, and then there's the diaphysis. Diaphysis is where the shaft most. most of the time is shaft, and then metaphysis is where the junction between now the diaphysis and the epiphysis. Okay, does this one metastasize? Yeah, it really does. Okay, it goes to the lungs. The treatment for this? Someone tell us, please. Anyone? You could just take a guess. Actually, the thing with learning is, even if you don't know, don't be embarrassed to say a word. Literally, the embarrassment of
Could we do
okay, it might seem
resection initially, and then if there is metastasis, chemotherapy?
okay. I wouldn't go with chemotherapy. Okay, Pia, it's fine. I was telling you, the embarrassment that you tend to feel like, you've answered something wrong and you feel like now you're embarrassed. Actually saves you a lot of trouble. That embarrassment is your savior. Okay? Because once you get embarrassed and you feel like now, I've messed up in this situation, you don't get to forget it easily. So whatever the answer is gonna be, this is gonna stick with you. Okay? So those are the answers. Go to the next slide. Okay, what do we have here? Anyone to tell me what's going on here? Just a general knowledge. You don't have to describe whatever that you're seeing on your screen. Anyone? Actually saying this is an X-ray picture is an idea. At least you know what you're beginning with. What part of the body is this?
Looks like the knee joint.
The knee joint. Is it inverted or is it just in the normal anatomical position? Lubna?
It looks inverted.
Inverted.
It looks like I'm looking at it from behind.
Behind? Why would you say that?
Huh?
Could it
Why
be
would you say that?
I'm not sure, but it really looks like to me that I'm looking at it from behind.
Okay.
Mm.
There's someone else who was talking in the background. I don't know who it is. Mister, what do you have to say?
a tumor of the femur, but on the lateral side?
No, I was asking, is this picture is the picture inverted or like it's in the normal anatomical position?
Normal.
Normal. Better. So this is the femur, this is the tibia, this is the fibula, and this is the right leg. Okay. What's wrong with this diagram? Now, usually they say pathology and physiology yenye imeenda combo. So most probably seeing a diagram like this type of discussion, you must know there's something wrong. This is not the normal. This is not how it looks like. Saizi hata tukikupiga picture it doesn't. There's something wrong on this picture. I need someone to tell me. A protruding mass from the femur. Great, great. Mushroom appearance. Okay. Mass growing from the medial aspect of the femur. Thank you, thank you. Fine. I know most probably you guys mtafunzwa this thing, and then you come back to the slides and revise. When you see it on the spots, inshallah, it will go easy for you guys. Okay. It's not a mushroom appearance. Actually, it's a cartilage capped bony projection. Okay. This is something they call osteochondroma, and it's the only thing that looks like this when it comes to orthopedics. Okay. You see a mass growing like this, like on hata ukiipata this side and then upate like it's moving outwards and projection plus this service ya huku nje has a very knobby surface. So you just know that this is osteochondroma. It's also called exostosis. Okay. Most probably this is seen in the long tubular bone. So going to the next question, describe the gross morphology. There's a bony protuberance here. And then on gross morphology, you'll always see something called cauliflower-like appearance. Okay. I don't know. There's supposed to be some questions that I don't know where. Most probably they'll just pick it up. Okay. So microscopy, what you get to see is bony couch by a row of cartilage. This thing comes from the cartilage. Okay. And then how does it present? Okay. Radiology, this is how it is actually. So pathology, you make sure you get to know how it looks like on a gross morphology. At least usikose kujua the microscopy. Very important. So some things that involve orthopedics and the bones and everything, X-ray is a must. Okay. Get to know how it looks like on an X-ray if it's necessary. Okay, some things like rest condition sphere. I think X-ray plays a big role. Okay, so when you know how it looks like, when it's presented to you like in a gross manner, and then you also get to know the microscopy, of which microscopy it will only, most probably it's all about cells. Okay, and then there's the X-ray or the diagnostic images that are being used, whatever it is, MRI, X-ray. But for your level, I think they'll just be talking about X-ray. Okay, so I told you before, it will have a well circumscribed dense tumor with a knobby surface. The clinical presentation is pain. Okay, pain. So this is the most common type of benign tumor. Okay, benign bone tumor. Sorry. So what you get to see with benign tumors is they are very painful actually. So usually, actually malignant ones, they are less painful compared to the benign ones. Benigns are very painful. And that's what brings the patient most of the times to the hospital. Okay. So treatment, anyone? Those guys who are typing surgery in the group, the group chats, the floor is yours. Okay, treatment is by excision when big. Ikikuwa kubwa, you cut it. And then for some reasons, I don't know why, but it tends to reoccur. So ikikatwa and then it grows back. It's usually symptomatic. You'd see it. Hauwezi miss actually. What do we have here? This one, Sasa, I guess everyone should be on the front line trying to answer this question. This is general knowledge, even before me. Yeah, this is Rickets. Okay. Got it. Now I need someone. You guys have been taught this, Cindy. been taught this. I was informed the phones are here. I need someone to tell me the pathophysiology of rickets, how it occurs.
Mm.
Anyone? Someone typing. I think I thought knocked knees present like that. Amma, what do you mean? Do you know Brian?
Um,
Oh, okay, I get you. I get. Okay. I think that comes more with trauma, but you see this one is a kid. Just the general appearance of the person. Ingekuwa ni mtu mkubwa, at least we could have had some differential diagnosis. Then this picture, okay, when this guy was young, probably now there's a defect in there's a deficiency in some of the vitamins that led to this.
vitamin D.
Pardon?
The deficiency in vitamin D, hence I think
Yeah. Thank you. I wanted to ask it, but you
yeah.
have gone ahead. Okay, now that you've answered that, could you just tell me how it occurs, the pathophysiology?
You have a vitamin D deficiency.
Okay.
And vitamin D, I think is important for the absorption of calcium and phosphate
Thank you.
from the kidney.
Mhm.
So if you do not have calcium and phosphate, you won't
Mhm.
be able to mineralize
The bone.
bone.
Okay.
Yeah.
Yeah, thank you. Actually, that's it. That's how it goes. Yeah, there's Gabriel Chwana saying secondary hypoparathyroidism. Yes, there's also PT levels that play a big role in this. Thank you, Gabriel. Okay, what are the clinical features a patient might present with other than the one that's shown in the diagram? We said this one is, but there are many ways of which rickets tends to present. Anyone? I'll just give you the answers. Sorry. Yeah. There's something called pigeon breast deformity. There's also something called frontal bossing and rachitic rosette. They are well explained in pathology, the pathoma textbook. You could also listen to videos. Thank you. Okay, what do we have here?
Excuse me. Excuse me.
Hello.
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 Yeah. On the former question.
Hmm?
Yes. Can you?
Let me take you back. Okay.
Yes. On that former question.
Mm-hmm. Trauma.
According to what I've looked into.
Okay.
No. I'm raising an inquiry.
Okay.
Because when I look at this,
Uh-huh.
person looks like a girl. Yeah.
Okay.
And
Yeah.
the positioning of the knees and the ankles.
Uh-huh.
Looks like a classical case of knocked knees.
Okay.
Rather than rickets. Because the person with rickets normally presents with oxbow legs. So I was thinking, didn't it be knocked knees, not rickets?
I'd go with rickets. It's because of the age and
rickets.
Yeah. But I'll have a look at it and then I'll get back to you. Your name is June O'Brien.
Yes, that's me.
Okay, kindly when I send the slides in the group, just reply to me privately. Okay?
All right.
Thank you. Guys, what do we have here? I didn't want this to appear. I was planning to have it come as just fly in just like the answer, but forgot in a hurry. Okay, what do you have here? Now that you've seen the triad, there's a triad here, known for a very specific case that you guys have been taught already. Even this name gives you a clue on what the answer could be. Anyone? So the kid on the screen has a blue sclera, as you can see. Okay, but the case that was formulated here says the boy presented with recurrent bone fractures, bone pain, hearing loss, but the bruise is absent. So usually what happens is when such case is presented to you, we usually call it child abuse. Okay, just because of the number of bone fractures. But to rule out child abuse, I've already said there are no bruises. They're already absent. I need someone to think in the right direction. Anyone? Look back. Look back there. Am I audible? Okay, you guys mnanisikia? Okay, something we call imperfecta, also called the brittle bone disease, something of the sort. Yeah. But it tends to present with recurrent fractures, bone pain, hearing loss, and then yeah, they might both tend to confuse you. You wouldn't even think this is from skeletal muscle. I mean, musculoskeletal pathology. Uh-huh. I want to ask you a question, okay, regarding this battle. I need someone to tell me why the sclera looks blue, okay, and also why there's a hearing problem associated with this osteogenesis. Anyone? Okay, that one you can read it for yourself. I think it's just nice to know. Okay. Hopefully they won't test you. But kindly read this. There's type 1 collagen here that's responsible for bone strength and structure. So in osteogenesis imperfecta, there's a defect, this connective tissue actually. I mean, in the synthesis of type 1 collagen. So the bone tends to be weak in terms of bone density. Now, what do we have here? Anyone? I'll always advise you, when you see a diagram, tend to figure out where that diagram is from, okay? So what part of the body are we dealing with here? We already know the system is musculoskeletal, and this is a bone. But from where?
Is this a femur?
Okay, seems to be a femur. It seems That's what I'd say. Okay, haina shida. Thank you, Lakini. What do you think is the diagnosis here? Do you think this is a malignant or benign tumor?
I think it's malignant.
Why?
I think it's malignant
Why? Why do you think so?
because of like the massive necrosis that's going on and how big the mass is and the involvement of the soft tissue. What's the cortical bone? I'm a soft tissue. I can't read.
Okay, it has already penetrated the cortical and then it has led to the growth of a soft tissue.
Mm.
Okay, so this is osteosarcoma. I think you've heard of it. And osteosarcoma always comes with a radiological feature that is unique for it. Anyone who knows about it? I wish I had an X-ray there. I would have shown you. I'll also add it here later on. Okay, the X-ray features that the osteosarcoma tends to present with, it's called a sunburst appearance, and there's also called something called Codman's triangle. It would be better if I had an X-ray. I would have shown you guys, but it's fine. When you guys will be taught this, most probably the teacher will mention that. Actually, they can't leave the topic without mentioning that thing. It's very, very special. Okay, and when they mention it, they'll try to show it to you guys. Okay, describe the gross appearance. Anyone? You guys, what do you use for your pathology revision? I mean, sport-wise, I don't mean even. Anyone? Okay, is there anyone who can just point out where the malignancy is, this diagram?
Is that the distal femur?
Yeah, this is the distal femur.
Yeah.
Okay. I mean, like the whole diagram shows the distal femur. That's the most special thing here, because this is the diaphysis. This is the shaft of the femur, and then this is where most of the things are. So, which it makes uh, saying there's nitrogen. The malignancy is in the distal femur. Kind of. So what you do, the tumor is located in the distal femur, as we've said already, okay? But in the metaphysis, okay? And it tends to destroy the what is this thing called? How do you change the epiphyseal plate, okay? And then it goes upward to some extent into the medullary cavity. Okay, all this whitish thing. So, okay, name two presenting clinical features that are seen here. The bones always work with pain. Pain is most of the time. Yeah. Let me tell you a trick actually. When you're doing your inetoje, your what questions, an advice from me, actually don't give out your paper when it's blank. Tafadhali. Whatever comes to your mind, when you just see a diagram, out of nowhere. It's yes, and then you send this to the heart, and you know a condition of the heart just right. Don't leave your paper blank. Okay, you're just gonna give that lecturer who was marking that you've been doing less work in school and you're not serious with what you've been doing, and he tends to assume even the right question that you're gonna answer in that page. Let's say like the whole page you've answered like 3 questions, left like 8, 9 questions blank. Okay, just gonna see you. This one is he doesn't even know what he's saying. Was probably this hata hizi zenye ziko hapa just guessing. Then you just mark it wrong and it continues. For him, he's gonna be paid. He'll be done with stuff. Okay, that's my advice. Don't leave your paper blank. Write whatever you see. Write whatever comes to your mind. Actually, one minute. 1 minute. If you don't know that question, 1 minute ni mingi sana. Utakaa hapo hadi ushangae if hii slide I move, at least I get to try my luck with the next question. Okay? Now, I've said this this is osteosarcoma, and the gross appearance, there are giant cells here. Radiological features, I've told you the sunburst appearance and Conman's triangle. Clinical features, I've told you there must be pain. Okay. The microscopic features of this one now. Anyone? I'll also attach in it. I'll also attach microscopic diagram that tends to explain about the cells that are being seen on a microscopy when you're viewing your sarcoma. Okay. So the common sites of origin and where it metastasizes, very usual. Oh, sorry. So this is the knee joint already. Okay. And then there's also the pelvic bone. But the knee joint is okay, here.
Shuhaib,
Hi.
Shuhaib,
Unanisikia?
how would you differentiate between this one, the osteosarcoma, and like giant cell tumor? Because you're saying you're describing the gross appearance and saying you're seeing giant cells, and and then a giant cell
Actually,
tumor.
this is
How
not
would you
supposed
differentiate?
this is not supposed to be. Not supposed to.
I'm sorry, that what?
Giant cell, the answer to this question is not supposed to be there. I think I just kept it here when I was tired.
Oh, okay.
But the morphology is the one that I described before. The destruction of the epiphyseal the plate, and then the malignancy extending after the medullary cavity. Okay, I'll just wrap this on later on when I'm sending the slides.
All right.
Okay. But then, does this thing metastasize to any part of the body? Yes, it does. It goes to the lungs and it presents as cannonballs in 90% of the patients. Most probably you guys have heard of this thing when you guys were doing respiratory, if I'm not wrong. Okay, what do we have here? Anyone? Just the normal description. I don't want you to tell me the diagnosis or anything.
Like a cyst.
Might look like a, okay. Okay, what do we have? What do we have on the main diagram? What type of tissue? The bone. You can see this is the cortex and then this is the medullary cavity. It's so easy to pick it up, to pick out. Okay, what do we have? There's something growing here. Okay, and also someone to remind me to attach it to the radiograph here. It's way better to pick it up on a radiograph than a gross morphology. Okay, this thing that you're seeing here is a round mass, which seems okay. On morphology, just try to explain whatever you're seeing with your own eyes, okay? It might give you a clue on the diagnosis, or it might just help you in coming up with the diagnosis, but just try your best, okay, to see if you can say whatever that is on the diagram. Just the same way now we're saying this round mass, and then it's reddish brown in color, okay, and then it is in the cortex, it's trying to extend the medullary cavity, okay. So I'd give you the diagnosis. This is something called osteoarthritis. You'd be taught about it. Most of the times, the cyst or the mass that you see tends to be like 1 centimeter. Okay, but ikienda sana haiwezi pita tu. Hata however much the mass is going to be malignant, like however long it stays, doesn't get past 2 centimeters. Okay, I think so. On radiography, this tries to present as an area of radiolucency. Okay, so radiolucency, bones are usually radiolucent. There's a radiograph here. Bones are usually radiolucent, but then this one, I don't know how it's presented, but okay. I'll see if I can get a radiograph here on that one. But then on the cortex, utaipata tu hivi kadot kakubwa tu hivyo on the cortex. Okay, it's very easy to pick it out actually. As I said, this osteoarthritis, it usually appears as a discrete oval or round mass of reddish brown tissue within the cortex of the bone involved, and then it usually measures 1 centimeter in size. But I said it can extend to be 2 centimeters, okay? But it can never be more than 2 centimeters. These rulers that you see beneath the diagrams, every time you see a pathological issue, kindly try to make use of it. In a way, it's guiding you on what you need to figure out. And then it's located in cortex. But this one tries to extend into the medullary cavity. How does it appear on a radiograph? Area of radiolucency surrounded by sclerosis. Okay, again, there's another tumor here. What part of the body is this? Anyone? No. Okay. This is the bone, the connective tissue. And here, this is the way it looks like. It looks like the distal femur, if I'm not wrong. Okay, because of the size and how the condyles are coming. Okay, so what do you think is wrong with this diagram? There's a difference in color between these two. Okay, so this is how the normal medullary cavity looks like. And then if you see this, something like this, probably it's an abnormality, which is telling you something that should not be here. Okay. Okay. The pathology of this is chondrosarcoma, okay, which comes from a cartilage. Okay. Where does it mainly arise from, and how does it present? Okay. Presentation, I mean, in terms of clinical features. I mean, what brings the patient to the hospital? Okay. So you'd see this one in the pelvic bones. Okay. This being the femur should also be there. But I just had to pick out the pelvic bone, the bones. Okay, there's an enlarged mass with pain and swelling. That's the main thing that is gonna bring the patient to the hospital. Okay, describe the gross morphology. Okay, the white is yellow thing here. I already told you. Looks more of a calcification, if I'm not wrong. Yeah, I'd go with that. That's easy to pick up actually. Okay, what types of cells do you get to see in chondrosarcoma? I mean, on microscopically, you'd find chondroblasts. What are the risk factors? A risk factor for this, I think one of the risk factors is an existing osteochondroma. I think there's also Paget's disease, but I don't mean the Paget's disease, the mammary, the bone. Paget's, I think it's called Paget's disease of the bone, and the other one is Paget's disease of the mammary gland. That is the one I'm talking about. Okay, do we have a next question? Okay, yeah, I think this should be the final question. Okay, yeah. Probably you guys are wondering what this is. Anybody who has ever seen this before? Any person who has seen that diagram on the screen before? Thank you. Thank you. Kevin Mololo. Again, just chest deformity. I think when we were discussing the rickets, we said it's also a way that rickets could present. Okay, the ribs tend to go inwards, and then the sternum comes outwards. Okay, the pathology is just the same as that one of rickets, mineralization of the bone. Okay, Harrison's groove, it is when it goes inward. Okay, Harrison, ikiingia ndani is when you call it Harrison's groove. But when it's presenting like this, it's coming outwards. This is pigeon breast deformity. I think I'm done with the presentation. Thank you so much, guys. Thank you for being patient with me. I know I've asked you. That's for your benefit. Anyways, now I'll stop sharing and I'll stop recording. Let someone stop recording.